Thank you, Ellie, and welcome everybody to our special plenary event. So, great way to close out the day today to talk about the value of healthcare data. So, with our conference theme being putting healthcare data to work, we're going to explore with a panel the implications for sustainability because of the value of healthcare. This panel was organized by Joe Porter, University of New Hampshire, and the APCD Council co-chair. Today's moderator will be Nicole Helvey from Virginia Health Information. This session was sponsored by Comagine Health, and we're now going to hear from Richard Gibson from Comagine Health. Richard?
Good afternoon. I am Richard Gibson, Medical Director of Data Solutions at Comagine Health. Thank you for giving me and Comagine Health the opportunity to open this session on healthcare data value and sustainability. The two key questions for healthcare are, number one, what needs to be done to maintain and restore the health of each individual? That's a question about knowledge. And number two, is each individual getting those needs met? That's a question about execution. Sustainability comes from the long-term payoff in answering those two questions. There's better mental health leading to better physical health. There are fewer emergency department visits and fewer hospitalizations. There's less chronic illness and disability leading to less expensive health care, fewer missed days at work, and overall higher productivity. There are fewer misdiagnoses. There are fewer inappropriate treatments. There are fewer medical errors, fewer medical complications, and fewer adverse effects of treatment. Where do we get these data? Using personal apps, individuals can enter their own goals about health and well-being, their habits and stressors, and information about their physical, social, and economic environment. Retail services can reveal an individual's genetics and microbiome. Public health and community-based organizations can assess health-related social and environmental needs. Electronic health records and claims data can tell us diagnoses in response to previous treatments. We know these data have value. How do we parlay them into sustainable funding for data collection and management? Payers and providers will pay for healthcare data that identify individuals at high risk for expensive adverse events, that close gaps in care, and that lead to just and equitable global payments for primary care. Public health and regional governments can fund data aggregation that leads to socially necessary services. Mobile apps funded by payers, providers, and government agencies can advise individuals how to manage conditions by themselves and when to seek further care. And finally, research is always willing to pay for trial participants. There are multiple parties that are willing to pay for detailed, organized data. To get to sustainability, we need to combine data from mobile platforms, claims engines, electronic health records, public health, and community-based organizations. We need to further vocabulary and technical standards that allow us to link an individual data across multiple sources. We need to seek truly informed consent so that individuals trust us with their data. These efforts are financially sustainable, but we need to lead the cooperative effort to gather, organize, and present useful data to funders and researchers. Thank you.
Richard. Now I'm going to turn the time over to Nicole Helvey from Florida, who will be today's moderator. Nicole, it's all yours.
Good afternoon, everyone. Thank you, Norm. Good afternoon, everyone. It's so great to see you all today, or those that I can see from here. I hope everyone can hear me. If not, just put a message in there in the chat or give me a thumbs down if you see my mouth moving and don't hear anything. In the meantime, I'm very, very thrilled to introduce to you today a panel of my colleagues from around the country who are doing some amazing work in the area of data and valuating data and thinking about sustainability for our data and our organizations. And as we came together initially to prepare for this session, it became clear to us that when we think about the value of data and the sustainability of data and organizations, there are many, many different angles at which to look at this topic, depending on your perspective and your primary audience and the type of organization that you are. And so thinking about it, I kind of wanted to frame and open that up to open up everybody's minds to some of the different ways of thinking. So if we think about it in terms of people, process, and technology is one way to look at it. If we think about the people that we serve, who are our customers, who are our primary stakeholders, thinking about topics such as their access and how do we deliver information to them, their literacy levels, how do we promote a data-driven culture and data-driven decision making to add value to our data, and how do we encourage trust in our data and in our ability to keep the data private and secure among those stakeholders. From a process perspective, I think we think about some of our direct processes, some of those methodologies, the innovation, the technologies that we use, the platform, physical things such as linking data and enhancing data. But then there's also some indirect processes, I think, where we can think about the value of data from automation processes, business process optimization, and even from a business intelligence perspective, informing how we're doing things and how we're performing on a daily basis. And then, of course, from a technology perspective, I think it spreads the gamut, right? Everything from our data management systems, our analytic tools, how do we deliver package information? How do we translate information and make it usable and consumable? How do we achieve interoperability with other data systems and other data sources that we would like to work with? And again, fostering that culture of innovation and data-driven culture throughout. So I kind of wanted to open up our lines of thinking there. Of course, across all of those, there's kind of some recurring themes where we think about, the policy considerations, the governance considerations, obviously privacy and security across the board. And then certainly, as we look at things through a lens of equity and integrating social determinants of health. So I don't want to belabor that any longer. I just wanted to set the stage, but I would really like to point the direction, if I could, to our stars for this panel, our guest speakers. And I'm going to allow each of them to introduce themselves, and I don't want to butcher their titles. So I'm going to run down the list, and then we'll go through one at a time. But today joining us, to name everyone, we have Kenley Money from the Arkansas Center for Health Improvement. We have Mr. Kyle Russell from Virginia Health Information. Jennifer Harper from the state of Oklahoma. And Jennifer, forgive me, I forget the name of the organization. So I promise we'll come right back to you. We'll hit you first. How about that? And then, of course, Karen Lee Harrington from the Maine Quality Forum and Maine Health Data. Hey, Karen Lee. So with that, I think it would be great to allow each of you a few minutes to introduce yourselves to the audience and maybe a little bit about your perspective, and then we'll get into the conversation. So Jennifer, as promised, why don't we let you kick that off?
Well, thank you. And thank you for being part of such a great colleague discussion on such an important topic. I'm Jennifer Harper, an administrative program manager for data acquisition, and that's with the Center of Health Statistics here at the Oklahoma State Department of Health. The Center for Health Statistics collects, analyzes, and disseminates health statistics in order for the agency as a whole to achieve its mission of creating a state of health for all Oklahomans. It manages primary data systems, including the hospital discharge data program, vital statistics, the behavioral risk factor surveillance survey, including operating an in-house call center for data collection, as well as management of the state cancer registry and geographic information systems. It also houses the data governance office for the agency. Did you want to go through introductions of everyone first, or do you want me to go into some perspectives?
Oh, sorry, Jennifer, I was struggling there with my mute button. Why don't we go ahead and go down the line, and that way we'll keep a round robin going to keep everyone engaged. Next on my screen, I see Kyle. Kyle, you want to go next?
Okay, I think I'm off mute. Great. Hey, good afternoon, everybody. Kyle Russell. I am the CEO at Virginia Health Information, or VHI for short. We are the nonprofit 501c3 health data organization for the Commonwealth of Virginia, and we have been that since 1993. Over that time, we've accumulated different data collection systems. We started back in 1993 with the state's hospital discharge system, and then another big milestone in 2013, we became the state's all-payer claims database. And then most recently in 2019, embarked on the endeavor of becoming the state's health information exchange. And so each of those different programs has their own opportunities and struggles that we've learned from, and has all kinds of different considerations, many similarities, but some differences in how we keep them sustainable that I'm happy to speak with you all about today.
Thank you, Kyle. Sorry, my mute button's a little slow there as well. Great to hear from you. We'll circle back. Next on my screen, I see Kenley. Kenley, if you're queued up, I'll go ahead and let you introduce yourself to the audience.
I am queued up. My name is Kenley Money. I'm with the Arkansas Center for Health Improvement. My title is Director of Information Systems Architecture. Wow, lots of syllables. I'm the APCD director, and my team builds and manages all the data assets at ACI. ACI, not ACHI, which is what I said the first time I came here. The Arkansas Center for Health Improvement. Get it? Anyway, we are a health policy shop that is administratively housed under the state's med school, the University of Arkansas for Medical Sciences. We're not clinical. We are a nonpartisan entity that supports state agencies and the legislature and the executive team of Arkansas in being a catalyst for improving the health of Arkansans.
Excellent. And we're so thrilled to have you here with us as well. And last but absolutely certainly not least, Caroline Harrington, who has been serving as our board chair, by the way, if you didn't already know that. And we really appreciate all the work that she's done. Karen Lee, why don't you go ahead and introduce yourself?
Thank you. Good afternoon, everybody. My name is Karen Lee Harrington, and I work with the Maine Health Data Organization and the Maine Quality Forum in the state of Maine. And we're going to focus on the work of the Maine Health Data Organization. We are the state's data center. We're responsible for the all-payer claims database, for hospital discharge data. We collect data on quality measures, hospital financial data, and I think there are probably a few other data sets I'm missing. We are an independent agency, which means we're part of state government, but I'm not part of a bigger agency. I serve at the pleasure of a board of directors, which is a multi-stakeholder board that is defined in statute, and the members of the board are appointed by our governor. So excited to be here and excited Nicole is leading us through this discussion. Sustainability is a really important part of the equation. So look forward to this discussion with all of you.
Awesome. Thank you, Karen Lee. I wanted to interject just one or two more comments, again, kind of framing and opening up the conversation. So as we think about evaluating our healthcare, thinking about who are our customers, what are their data needs, and then how do we transform that data into consumable and meaningful information and deliver that to those primary customers? And how do those customers derive and define the value of that information for themselves? And then as we think about value of our assets, there's many layers to that, right? So there's primary value that we can derive, on direct ROI. Then there's things like secondary value. So in the case of maybe a transparency website, if there's an organization that collects and processes that information, maybe they sell it to an employer who puts it on a transparency website for consumers. So there's the first layer. The second layer may be the savings that are gained, by those consumers' cost services, for example. And then a tertiary effect might be policy changes that are implemented, maybe funding for APC, different ways that payment models are. So just kind of opening that up again. Without further ado, Jennifer, I wanted to talk about a little bit what you're doing, your take and your perspective on data valuability.
Thank you. Well, being a principal statewide data resource, the Center for Health Statistics partners with several stakeholder groups who benefit from the value of data that we make available. Some examples of use cases and value observed by the various stakeholder groups, I'm going to speak directly to hospital discharge data collection program and some of the data products related to it. I'll circle back to some additional data systems as we get going. The hospital discharge program collects inpatient, outpatient surgery, ambulatory surgery, and most recently, emergency department data from facilities across the state. This data is shared with our stakeholders by way of a public use data file, or PUDF, And that's most used by the facilities who submit the data to us, but also by researchers and community organizations, advocacy groups, those types of things. We also share data by linkages with legislatively approved departments across the agency and analyzed responses to queries that are presented either by legislators or by representatives of the public. And one of the main uses or ways that the data is used is to assess burden and allocate resources. And this we see across the agency as well as within the facilities that submit the data to the program. So in terms of across agency, we find that the discharge data supports data quality and completion across other systems. So for example, the cancer registry links directly to hospital discharge data and provides values for missing information in reportable use cases. So for example, race and ethnicity may be missing in many cases, and that information is then derived from cases that are found in the discharge data. What's of value for the registry is that there's, according to the CDC in their grant, there needs to be a certain amount of completeness for different variables, especially some of these demographic variables. And if they're not met, then the quality of their data within the registry could be negatively viewed or negatively perceived. There's other grant-related reporting relationships across the agency, again, related to registries and their quality of data, again, adding to maybe missing data, but also assisting with tight reporting deadlines. So from one perspective, it supports other areas within the agency. Outside, we find that facilities leverage the data that's published and publicly available in order to inform their market analyses, but also some strategic planning and even equipment purchases. There was some reported cases of reviewing frequency of different conditions and looking at geographic distribution of those conditions in order to inform purchasing of large medical equipment and justifying the cost. The relationship we have with legislation and our legislators specifically can be described as a partnership, where the role of the Center for Health Statistics is to provide accurate, neutral data for various public health data collection systems and support that conversation among the different perspectives and support data-driven discussions and ultimately data-driven decisions between the legislators. There's been considerable and consistent support for data systems by the legislation. Specifically with regards to hospital discharge, we found that much of the data governance has been legislated. The use, the dissemination, who has privilege to view identified versus de-identified data has been written into law in Oklahoma, so there's very little ambiguity regarding data sharing and data use. There's also legislation in place in order to facilitate data completion and data submission, which has resulted in between 80 to 90% of facilities responding within the required timeframes for data submission. From a monetization perspective, access to data and analytics has been largely written as a fee-for-service model, which reduces state financial burden in supporting these programs. And so having that, not fully self-sustaining, but that approach where we have some income to support the data system further adds to the value since there's not as much public support for it. So in terms of value, the data products that result from the discharge data have a tangible impact in the public health conversation here across the state, and in terms of services that are provided. In terms of sustainability, we look at the financial aspect, of course, but also the importance of technology and having modern technology that can manage the contemporary data needs. It's interesting here locally that technology support, such as the databases, the servers, and infrastructure, are managed by a different agency, which is outside the scope of the Oklahoma State Department of Health. And so, as a potential challenge, in some cases, working across agencies in order to manage data and data systems can add a complexity. In terms of opportunities for future growth, there's discussion and initial planning phases for implementing an HIE that is also managed by a different agency outside of the agency, though the records from the HIE will be available in order for further understanding of burden and service providing. I'll stop there and let others chime in, and I'm sure we'll have more discussion as we go.
Jennifer, thank you so much. That's an excellent perspective and a great way to think about it. I think we'll stick in the same order for this round, just so folks know when to expect. So Kyle, that'll bring you up next. And I think when we talked, you had a similar, but a little bit of a distinct angle as we thought about sustainability from your perspective. You want to share?
Yeah, for sure. I mean, I know when we were doing the meeting to talk about this presentation, I came coming in being like, oh, well, we're all going to think the same thing, and then we'll just kind of divide up like who handles that topic. And then it was very clear, like when we were talking through, it's like, oh no, this does mean have a different meaning to each of us, which probably will make the presentation session a little bit more lively. I know. So I'll kind of tackle it in two parts to what you teed up, Nicole. So first off is like thinking about like who do we serve and like what is the value that we're providing to them. So I mentioned at the top, like we administer these different systems, right? We got the HIE, we've got the ABCD, we've got the hospital discharge data. And those, like if you break those three down, it's like there's three core data types that we provide right now. You got ADT, admission discharge transfer, you got claims data, and you got hospital encounter data. Each of those three, I feel like has a distinctly different core user that for us is probably 60% plus of our requests for who's driving the value and sustainability of those programs is different for each of them, right? So for ADTs, like that data is real time, it's really quick. And so our core user for that is absolutely health plans. Like they really want that information. There's a big value add to them in being able to get that data from providers way faster than it coming through their claims system. For APCD, our core user is researchers, just because of the analytical flexibility and what you can use an APCD for. It's got its limitations, but there's just so much meat on the bone. It's so research friendly that they love that. And then for hospital encounter, that's really back to the providers. It's information they can get on their competitors for business intelligence, essentially, right? And that use case is held up for like 30 years. Providers want to do that. And so we've got these core constituent groups, but they're different depending on the type of data and the type of use case we're supporting. All right, so in terms of like when I thought about like sustainability, you could think about that at a program level, or you could think about it at an organization level, like as a health data organization, like how are we sustainable? I think there's three threats that came to mind, and then thinking through like some of the strategies to address them. So first is loss of exclusivity of our data assets. Second is public funding levels probably being unsustainable. And then the third is talent loss. And I think those are pretty uniform for all three of us. So the first, like with being public sustainability levels, like I won't be surprised, like, you know, if the state coffers in most of our different areas get hit a little bit, maybe next year. And, you know, we're all very dependent on that as a revenue source to kind of do what we do. And so we do have to kind of look at it as like, how do we diversify our funding streams to sustain our organizations? And so there's like two things I thought of where I'm like, yeah, we got to make sure that we do this, right? The first is like for your APCD or hospital discharge system, like I'll say before we started operating Health Information Exchange, the idea of like getting money through our Medicaid agency through like the MES program or what an APD was or any of that stuff, I had no idea that was even a thing. Like it was like, oh, well, no, we'll get our state general funds and then maybe we'll generate some licensing revenue to make it all work. But then like on the HIE side, that's like the bread and butter of how things get sustained, right? Is getting that state portion to go get federal matching funds that you can go just fine do it. And so we started doing that for APCD too. And it doesn't, it's hard to justify the same like coverage level as what you get for Health Information Exchange. But if you're in a state that is looking at how you fund your APCD, or you have an APCD or hospital discharge database right now that you're not getting at least some fair share allocation through your Medicaid agency, that's probably money left on the table that you could stretch your state funds even further than what you have now that I would make sure to look into. And then the second is baking yourself into required reporting that the state absolutely has to have. So we all get requests for things that I would say are fairly discretionary. And then we get requests for things where it's like, oh no, someone's going to have this every year. And I would say the latter of like, we're going to be baked into a report that's required. I would do that even if there wasn't any funding at all and just take it on the chin to do it, because I know when time comes for cuts that it's going to be really hard to cut something that a required report has to come out. And if they had to go get another data source from a commercial source, it's going to be way more expensive. And so I that kind of playing preventative maintenance on, inevitably when, there are some financial constraints to try to better weather that storm through it, I think is really big. So the second, I'll cover talent loss, right? So we can all have a good thing going, but we all have very small staffs that are very reliant on, key individuals. And it doesn't take many hits there to feel like, oof, we're really struggling to do it. And there's no really silver bullet for that. I would say that I think most of NADA's membership is nonprofits or state agencies. So shocker, we're not the highest paying organizations in the world. And we typically are competing for talent that is very free to go work for a for-profit organization that could probably pay them more than we can. And so it's like, all right, well, we still have to staff organizations. Like, how do we do it to be more resilient? So, what we've tried to do is really double down on like, well, we can't pay the most, but how about we pursue like a really good quality of life and flexibility, and try to think about, it's like, what are we bringing to the table as an employer when it's not all about the money? So you got mission, you got flexibility, and it's like trying to make that value case to your employees that they know, right? Like, it's not like people are unaware of kind of what the market is, and we're all here trying to compete. And then also to make it like relying on, you don't want to rely everything on your vendor for everything, but having certain processes, I think, relied on through your vendor makes you a little bit more resilient to staffing turnover. So I think that's definitely a balance. And then the third is loss of data asset exclusivity. So with things coming on the rise, you've got way more commercial solutions for how you can get discharge encounters and claims, and they might not be quite as inexpensive, but they are out there. And or the federal pricing transparency changes, like there are certainly things out there for use cases where it was like, oh, we were the only thing. And then now there are other things out there. We kind of have to up our game, right? If you're not the only show in town, then there's a bit more pressure to make sure that you're really passing that value proposition. So I think for that, like one is making sure to partner with the different organizations. Like we tend to do our best when we're providing data, but a vendor maybe is providing tools to a downstream user or something. So those strategic partnerships are saying, just based on how we're structured, we're typically going to be the lowest cost way to get access to certain types of data for a downstream user. Like, how do we tackle that with, like, we're not in the business of making tools. So like, how do we partner with that? And then I also just want to hammer home, I think, the incredible importance as we move forward with multi-state collaboration for how organizations request data and how they use data. Like, I think the times in the past of being able to get away of just being a single state for certain things, like I said, as the market gets a bit more competitive, I think being able to facilitate and support use cases that aren't just strictly focused on one state is going to be huge. So Nicole, with that, I'll kind of finish up my comments and I can hand it over to Kenley.
Awesome. And you queued up another thought that I had from earlier that I neglected to mention. Kind of another one of those overarching themes is, the variety of data types that's ever growing, the universe of the data types and the data volume that's ever growing, and how do we keep up with that, not only from a loss of exclusivity perspective, but where finding value in some of those and achieving the needed interoperability and integration with those. So really good points. And I think, gosh, it was almost like we planned this. I think that cues up really nice for Kenley's perspective, if it's similar to what we had talked about before. So I think that sets the stage well. And Kenley, I will let you take it away.
All right. Kenley Money, Arkansas Center for Health Improvement. I noticed that my little name on my video doesn't have my last name. Sorry. And here well, first let me say everything we say will be a little bit repetitive, but there's value in repetition. But of course, everyone has their own challenges. At ACI, we've been around now almost 25 years, excuse me, as a health policy shop. And even though I introduced the all payer claims database, it's important. I'm going to provide just a little bit of exposition to set the stage. ACI has had an health policy analytic database since 2003. We call it the Health Data Initiative, and it was sort of a precursor to APCD. And from that data set, data resource includes the vital statistics data, the hospital discharge data, emergency department data, et cetera. We are not the state agency that manages that. We are not the health department that collects and aggregates those types of data. We have an agreement and some legislation from 2003 that enables ACI to receive these data and integrate them to support health policy projects. And as the years went by, these data grew. We did get some claims data from the Employee Benefits Division for public school teachers and state employees. We got some dental data. We got Medicaid data. We got some Medicare data. And integrated it into this original database. The questions that we answered with this database, we had to put in our mind, will the answer make a legislator happy? Any legislator. We couldn't just take any question and deal with it. It had to be related to health policy in Arkansas. That data we could not sell, we could not distribute, we couldn't do anything. We have exclusive use of those data. So along about 2012, my director, Dr. Joe Thompson, popped down the aisle and stood in front of my desk and said, "You think we could build an APCD in a couple of months?" And so what do you say to your boss? Sure. But that was the genesis. And from that, the HDI, our little one, grew, and there was another mandate, and hence the APCD was born. But so there was sort of a foundation of value established with state agencies and the legislature, et cetera. But this was a whole new world, as you know, because now we were asking carriers to give us their data. ACI, we originally thought we'd own the whole process, but ultimately we used Cycle 3 monies with the Arkansas Insurance Department to partner with them and build the data. ACI is, for all intents and purposes, the vendor, but still we have such ownership over the data and what we do with it to serve the public good in Arkansas. Anyway, so the carrier said, "No, we're not going to give you your data." And then we got a mandate, and the APCD was truly born. So the big, over the years, you learn a lot. The biggest value, of course, to date is to support health policy. We have not yet ventured into required reporting, which is a brilliant idea. And we are, well, an upcoming threat to us, which we will all face, is a change in leadership at the governor's level in, well, the election's in 2 weeks, right? And so the candidate that will probably win doesn't have a lot of experience in policy. And so we will have to bolster our relationships and really have an external stakeholder engagement effort to retrain and reintroduce and everything the APCD, because as I said a moment ago, we partner with the Arkansas Insurance Department. They're the authority. So if a data set is sold, they're the ones that collect the money and sign the data use agreement. And then they pay us to be the administrator, the vendor, right? So there's a real good chance that our commissioner, the Department of Insurance commissioner, will be replaced come January. And he's very pro APCD. So over the years, I would say those types of threats are the worst to us. We are the most dangerous to us. We have some state funding, not a lot. We could always use more. We are not self-sufficient. We do not sell enough data to take care of ourselves. But all those threats are an opportunity as well, because we will continue to court our stakeholders. We will build new data products. We've already begun discussions. Let's change how we sell data. Let's change how we deliver data. Let's change how we process data to tighten things up and make things more efficient. There's always change, but sometimes there's more energy behind it, right? And there is right now. I don't know that it's too little too late. I don't think so. You never know, right? But I think that we'll be all right if we are open-minded and flexible to change. I'm going to harken back just a minute. When the mandate was passed to require the carriers to deliver data to us, we had a hard sell. And so creative minds got together, and my boss will probably go, why did you call it the APCD? Because while that is a ginormous component of our solution, really Arkansas has the Healthcare Transparency Initiative. And in legislation, that's what it's called. Transparency, healthcare transparency, which is made up of the APCD and some other stuff, right? We have the health department data, et cetera. Who can say no to transparency? So we will capitalize on that most certainly as we move forward with our new legislative and gubernatorial partners. ACI, I'll say one other thing. We have the largest user of our data is a group within the University of Arkansas system. Well, actually, it's all more than just that. Arkansas State University as well. It's called the Arkansas Biosciences Institute, which is almost neither here nor there. But this is a group of university level student, PhD candidate, and professorial level people who mine the data. They have purchased a copy of our database of the APCD and its supporting data. They're even able to utilize the Medicare data. We have created this data package called a subscription, which allows multi-use under a single data use agreement, as long as it's all toward a particular topic. And we have 30, 40 users of these data. We get a large sum of money every year for that. And they publish off of it, and they work with it, and they call me all the time with problems, which is great. And one of the things we're going to try to do is to sell more of those, even if it's different levels, because it's excellent exposure. Every single paper that goes out of that place has the Arkansas All Payer Claims database in it. So good publicity, right? What's the moral of the story? Be creative in how you sell your data, as long as it doesn't make any lawyers mad. So I'll stop there and turn it over to Karen.
That's such a great lesson, Kenley. I love that. Karen Lee, I know you have a great talent for kind of rounding things up and bringing things home. And I know we have talked in separate conversations about some of what Kenley touched on, really how to articulate, that value to those important stakeholders. So I wasn't sure if you wanted to include that in your comments or if you want to address that, but I will let you take us home on this round.
All right, I'm going to be quick because I've got the easy job being last. Everybody has hit on, I think the real critical components of sustainability. But so let me focus on maybe 4 things. I think one of our greatest challenges when talking to legislators and stakeholders, is explaining what we do. People don't understand, right, what a huge asset it is that we have. And so I think one of the key ways to help build a sustainable model is to build relationships with champions within the governor's office, within your legislative committees of oversight. Find people that will listen and are interested and figure out how you can help them solve a problem with your data. They become your champion and they help you get to what Kyle was saying. And Kyle, you stole my thunder, around getting yourself written into legislation. And I'm going to list off a handful of things that MHDO in the last several years has become part of. We're now in the laws around workers' comp, surprise billing, Medicaid rate setting. We work with the Maine CDC. We work with the Office of Affordable Health Care. We work with the Pharmacy Accountability Board. We are now responsible for primary care spending reports, behavioral health care spending reports, promoting the transparency of healthcare on cost and quality. We're help the folks that work on ambulance pricing for the state. We're working on transparency of prescription drug pricing. All of this stuff is in statute. And that's how you stay around for as long as I think we've been able to, because people are now understanding how we can help support these really important laws that have been passed over the years. We're part of the reinsurance program. We're now providing information on high cost claimants and helping that program figure out how to spread its funding. We do work with the Department of Corrections. I mean, the list goes on and on and on. So if there's anything that I can share in terms of my wisdom over the last 10 years, it really is find the champions and work with them, and they will help you because legislators are running around with a million other things that they got to deal with. And they're not going to pay attention to the details of something that, although we all love it, it's a little bit of a snooze fest for a lot of people. They're like, what? Data? Huh? You know, so you got to find something that will grab their attention and that they're passionate about, and then show them how you can help them make whatever they want to do more understandable or more reliable, or whatever the case may be. The other two things I want to say quickly: build relationships with your data submitters and your data users. The people that submit data are equally as important to me as those that use our data. And it sometimes bothers me when I hear others say, oh, our data submitters, you know, we have to beat on them. And I will admit there is some frustration at times with, you know, there's a natural sort of give and take. The data submitters, if given their choice, they don't necessarily, they probably wouldn't submit data, right? But here's the thing: they are our customers, and we need to treat them that way. And I think we've worked really hard to do that and build partnerships with them so that they understand why it is that I come to them and say, we got to change the rule again. We need this data element, or we need that. Make the connections, connect the dots for them. Have meetings with the submitters and the users so that they understand why it is that we want this data, how it's being used to help inform policy. And by the way, in a lot of cases, our biggest users are our hospitals. So here's the other connection that you can make. You got to improve the data. If our data stays stagnant, we will not be sustainable, right? Our data's got to continue, and these points have already been made. We have to be nimble. We have to move as data needs and how people want to use data change. And the best way to do that is when you have hospitals and health plans that are also data submitters are data users. And when a hospital who's wanting to use the data to do planning, to better understand what resources they need to bring into the community, et cetera, and they're looking at the data and they say, the payer information that comes through in the hospital data is really crap, or excuse me, is not that good, right? So I say to them, hey, I'd like to introduce you to the person across the street that submits the data for you, right, for your hospital. Because I think if you guys talk and you explain why that information is so important, then they may have more incentive to try and get to better information when they're submitting it, right? So make those connections, connect the dots. It's all part of a sustainable model. If we can't get good data in, we're not going to release good data out. It's got to be a cohesive, collaborative type of thing. The other thing, just real quickly, is, as has been said over and over, and I think I just said it, we've got to constantly be thinking about the future. If all we're caught up in is right now, we will not be sustainable. I have been thinking about for years integrating the cancer registry and vital statistics with our claims data and hospital data. And it just happened this past year. A law was passed and it's happening. And we're going to start releasing a combined data set the end of this year. But that was years ago, right? And it took that long to get it through the process. So it's hard to do when you're trying to, what's the saying, right? You're flying the plane and you're also trying to rebuild the engine. But we have to be figuring out ways to do that. And I think one of the best ways to do that is through networking amongst ourselves and understanding, what we all are thinking about in terms of the future use of healthcare, how people will use it, and working together to kind of figure those things out, I think is really important for our overall sustainability. And I will stop there.
Awesome. I knew you would be able to wrap that up really well for us. I want to go ahead and take us. There's a great question in the chat from Betty Harney. And she's curious about the size of the data that we each maintaining. How many covered lives are in each of our APCDs, and are there any lessons learned while addressing the challenges of large data sets? And I'll kick that off. I know in our state APCD here in Florida, we have about 11 million lives amongst the plans that are submitting. And lessons learned, I would say, I'll circle back to that. I'm going to let these folks kind of kick off on that and see if I could add anything. And do we want to mix it up? Anybody jump in?
I can go.
To say the same order. Go for it, Kenley.
Okay, so Arkansas has some between 2.9 and 3.1 million residents, but our data begins January 1, 2013, and we just got it released through March 31st, 2022. But that doesn't mean we have 3 million people in our data. That means we have like 5 million or maybe 5.5, because people come and go, and babies are born and things like that. So I just want to put a caveat around that question. At any given time, we strive to represent about 3 million individuals, but over the whole thing, it's a lot wider. And the whole data set, though, because we have all the claims and all the pharmacy for that period of time, we have processed for our small state since April 2016, when we started this journey. We've processed somewhere around 10 billion records.
That is definitely impressive. Definitely. Who'd like to jump in next?
I made for APCD. I mean, so it's going to roughly correlate to the size of the state, right? Like we all are going to be somewhere in the range of a certain percent of the state's population are in there. I mean, I feel like for us, right, the APCD is big enough where it is like cumbersome to use. You can't just give it to anybody, right? They've got to be sophisticated. But then it's not. We hear a lot about how it's not big enough. Like there's certain things that's still be in it that are not. I mean, I think the difficulty is less so with the size and more the structure. Like hospital discharge data, it's smaller, but it's also way easier to use. Like you've got one record rolled up for like a hospital admission, and that is just awesome. Like you count the number of records, and that's like how many discharges there were, and you can see everything in this nice, clean one line. And so it's like super user friendly. For APCD, with having this transactional level, like line level information, so many times people say, oh, we want all the data, like we want it at the most granular level possible, and we give it to them. And then the reality is that they can't really use it like they feel like they're going to. And so it is tough when you've got data that can be used for all kinds of different things, but you're either going to have to curate it quite a bit for them, or only a small subset of users can really use it. And so it's great potential, but it's I don't know. It's like super fast car, but if you can't drive a stick or know how to handle it, then it's, it doesn't really matter.
Yeah, but we're all data geeks, so we love that stuff.
Yeah.
Well, we
Well,
do, but the people requesting it sometimes, like the.
Speed limit signs, they don't mean anything.
And Nicole, if I could just add to what Kyle just said, I think that is one huge opportunity, and I think this is part of the sustainability model in the near future, and that is finding an analytic platform that we can run our data through, right? And that a user with some simple points and clicks, right, can produce information. Because a lot of times what people want are counts. They want to know how many diabetics are there in the state, or how many people have been to the ED due to an opioid overdose. And here's the thing. Our data, as Kyle said, is fabulous. It can answer questions like that. But if you don't know how to use the raw data, which is to the person that's asking the question, it's big data. If somebody says to you, oh, I'm going to use an Excel spreadsheet to work with your claims data, right? That's like a big red flag. No, you're not. And I am not, I don't know the first thing about databases or anything like that. But what I do know is this is big data, and it's very difficult to use, and you need a certain level of expertise. What I think we need to figure out, and I think the states need to come together and talk about this, is can we find, and there are consultants out there that have built these things. I think the challenge is we haven't used them, and they're still difficult. We've got to find something that is easier and more accessible so that people can, again, through a point and click, get some basic information so that, the value of this is much more broad and it's not restricted to just a few. And it's more timely, because a legislature or a legislator that comes to you, or a governor, and says, I need to know how many ED visits there were. We cannot take 3 weeks to figure that out. We need an answer like that. And that, to me, is really the next thing on sustainability.
Yep, agreed. I agree with that.
Karen Lee's trying to get like 100 vendor emails, it sounds like, after coming out of this. That's what I heard.
I'm going to let Jennifer weigh in on this, and then I know we just have a few minutes left, so I want to make sure.
One thing I'll add, so Oklahoma collects approximately 3 million discharge records annually. Some of those records are collected multiple times due to the error correction process. So the data in the database turns over quite a bit in the collection of those 3 million records to assure quality and completeness in it. But in terms of lessons learned in addressing the challenges of handling large databases, we recently sunsetted a legacy data collection system. And so it really emphasizes to me the importance of having contemporary technology in order to collect and manage the large amount of data that comes in. Some of the challenges experienced with the legacy system was just too large a volume of data coming in order for the system to handle it. And we received, some comments, we'll say, from our partners and facilities who had to use some of these systems. And so in the spirit of treating them like our customers, as well as modernizing, we found that we can gain efficiencies by putting in place some more contemporary technology, and at the same time increase the customer's experience.
Mm-hmm.
Love that. Great point. I do want to point out we have a great question from Al Persenka in the chat, just asking about whether or not any of us are seeing support for the APCDs from our self-insured ERISA community, post the Go Bell decision, of course, and whether or not there's any ideas to garner additional political support moving forward. So with that, I want to point out we just have about 5 minutes left. So I want to give folks a chance to weigh in on that, and then we'll do one quick final round of closing takeaways.
I'll start. Generally, no. However, Northwest Arkansas, which is where the University of Arkansas Fayetteville is, there's a big corridor there where Walmart is and Tyson, big companies. The economy of that corner of Arkansas has just exploded, and there's a lot of interest, largely funded by Alice Walton, who cares where the money comes from, right? But in healthcare and health organizations and health systems. And so we have been ACI's actively up there talking to those big entities to see if they would voluntarily provide data to the Arkansas All-Payer Claims database. I say our chances are pretty good. It hadn't happened yet, but you have to capitalize on small things that happen in your state.
And I think they get the value. I know they've launched their centers of excellence model, so that they know the value of claims data for sure. Anyone else want to weigh in on that?
I don't want to end on this. That's the only thing. It's like I agree
we'll
with
do a final round to take away.
Frustration. I don't know. We don't have time to kind of go into the trial and error of it. I mean, I think that they see value, but it comes back to like there's a few things working against it that are difficult. One is, even if we, like, for instance, we adjusted our system so it's like, hey, we don't have to take the actual identifiers in anymore. And we thought that was going to be like really marketable to employers to say, hey, you don't have to submit your employee social security number to participate. All right, but then the question is, all right, well, is it de-identified? It's like, well, no, it's not technically de-identified. It's limited data set. Boom, that's hurting you right there because it seems like still too sensitive, And then also submitting data to one state, right? Like even an employer that's in one state that has a big presence, they're typically going to say like, all right, well, that's cool, but like I've got 10 other states, and so like they either sometimes have to opt in for all of them. They don't want to do that, or they don't see the value in opting into one state, like. So there's definitely something there. I feel like with in this community, I know a lot of people are trying to figure this out. Like we're gathering together to come up with some different strategies that as a community, there's a lot of things that are to be optimistic about. But up to this point, it has been kind of a frustration, I would say, for us. So sorry to have to end like that. But
so Kyle, I'm gonna balance. Can I balance Kyle's point with build a relationship with your purchasers alliance if you've got one in your state? So they're called either a purchasers alliance, a coalition of employers. That's what we've done in Maine, and we've had some really great success. The largest self-funded ERISA plans in Maine are submitting their data to us on a voluntary basis. It's not everybody, but it's the largest ones, and it's through that relationship with the purchasers alliance.
Yep, the head of our business coalition was our biggest advocate for our state APCD, and that relationship is so valuable. I want to do one more quick round. We got about 2 minutes left, so I want to give our speakers a choice of what they might want to address in their last comments. I wanted to think about ways that we think NATO could help support our organizations in evaluating their data and their knowledge assets, thinking about also your methodologies and some of the things that you do. Or just any other lesson learned or takeaway you'd like to leave with our audience today. And so just for simplicity and for the sake of time, we'll go back to the original order, not to put you on the spot, but Jennifer, if you'd like to start.
Sure, happy to. The partnership with NATO has been especially helpful and particularly in the last year as we've been navigating some technology transitions and changing out the technology platform that the hospital discharge program is based on. And not only in the colleague sessions that happen throughout the year, but in addition, members and Charles and Norm also carved out time to speak with us individually about their related experience and things to look out for and watch out for. And so the colleague relationships have been tremendously helpful in navigating what could be a rather complex process. And so we've been really appreciative of that.
Love that. Love that. Go ahead, Kyle.
I said just to echo a couple things that I just really agree with from Kenley and Karen. Lee came after me. So to Kenley's point, like administrative changes are really, we've gone through that recently. But it is also this opportunity for us to be a source of stability to say when things change, we're here, and we have to be that consistent presence. And so I think that's going to underscore our value. And then to Karen Lee's point, just the importance of being a good partner and treating your data submitters like a partner. And obviously that's a different it could be a different type of entity regardless of the data system. But if the organization is getting data to you, that's not a very sustainable process for different things. And so you've got to have that balance and build that trust and, kind of triangulate everyone involved in that process to be a kind of a good steward to all. And so I completely agree with that. And I just think that's such an important point that needs to be core to different things that we do with these different programs.
Couldn't agree more.
Okay.
Couldn't agree more. Kenley.
Given that this session was about sustainability, as you begin the journey for an all-payer claim database or some data asset like that, remember, and don't be afraid to know that it always takes longer than you think. And as you build your plans, know that, understand that, and don't let it frighten you, because if operationally you're undone, then leadership is going to be undone. So be calm, don't be scared, and know that it will always take longer than you think it should. But that's okay. Just budget for it.
That's great. How about you, Karen Lee? Love it.
I'm going to say real quickly, who would have ever thought that managing data would be so much about relationships? But that's really what it comes down to in my mind in terms of sustainability. And the relationships take all different kinds of, there's the different aspects to it. Whether the relationship's about, finding a champion, or whether the relationship is about being a good steward or a partner, or networking, collaborating with our peers. It really comes down to, in the last 10 years that I've been doing this, that if I didn't have the relationships that I've got today, I think things would look a lot different. And I'll just say really quickly, the other real key for us with sustainability is having a relationship with a good data vendor, and that you're a partner with. So to me, again, who would have thought data and relationships, but huge.
Love it. Love it. And I do want to point out, Norm put some nice information in the chat for us about an upcoming webinar regarding the ERISA. And I think what I'm taking away, some of the lessons I jotted down for fun, is just don't make the lawyers mad. Make sure that we are persistent. Find those champions, and don't forget to look at your submitters as your partners and champions. And to Karen Lee's point about making friends with your legislators, I'd also say don't always focus on the biggest fish. Sometimes those staffers can be your best friend, because oftentimes they have a little bit longer longevity in their positions than even their bosses do. So sometimes look at the little fish, and you may get you a long way. And with that, Norm, I will turn it back over to you. I want to thank everyone for your time today and your interest, and thank our panelists. Such a great discussion. I knew this would be a great discussion, and appreciate all of you. So Norm?